Thank you very much. It's really a great honor and a privilege to be here today. And this is going to be an unusual lecture. It's a little different than what you're used to. Most of the time you go into a lecture hall, you have about 50 minutes, and about 10 minutes in, everybody's on their cell phone. This one is actually going to be a very, very different kind of lecture. So buckle up, it's going to be a bumpy ride. Now, today we're going to talk about myths. The phrase that I like to use is a bubbemeise, which is Yiddish for it's an old wives' tale. It's an urban myth. So when I was a kid, my mother would say, if you go outside with wet hair, you're going to catch a cold. Now, clearly that isn't true, but it's still widely held belief. And there are many of these myths, like, most of the time they're incorrect. You don't have to really wait an hour after going swimming and you won't cramp up and die. On the flip side, though, is, chicken soup might be a good thing if you've got a cold. But there are a lot of myths and misconceptions. And one of the things that, there we go, okay. So today's lecture is really based on a new project that I've been working on for a couple of years, and it's really dedicated to Ron Littman. Ron was one of the greats of his generation. He passed away a couple of years ago. Ron was a polymath. He was a fantastic teacher, writer, clinical researcher. He called me in 2021 out of the blue, and I never worked with Ron. I only knew him from national meetings, and that's a plug, actually, for all of you to go to meetings. This is where you're going to meet your colleagues from all over the world who will become lifelong friends. You can't do that over Zoom. You have to physically be there and interact with people. I met Ron at the Society for Pediatric Anesthesia meetings, and we became really good friends. In 2021, he called me out of the blue and told me this story that he had terrible cancer. It was going to end poorly. He had just had his second bone marrow transplant. He was too sick to go back to work, but he was too healthy to just be watching TV. And he had a realization that I think almost all of you probably have, or if you don't have, you should have, and that it is simply impossible to keep up with the medical literature. There's too much. You don't have the time, and even in a narrowly focused field like pediatric anesthesia, there are probably 30 journals that come out every month that have topics that are of importance. There's no way that you can even scan those titles. And if you think about it, if you still get subscriptions to journals that publish physical matter, you probably have a stack on your desk this high of unopened magazines. So what Ron realized was that at home, he could scan the articles, review them, and not just put in abstracts, but put his thoughts in about the positives and negatives of the study. And he created what was called the Pediatric Anesthesia Article of the Day, and that is posted every day. And it covers these important things in pediatric anesthesia, pediatric critical care, pediatric pain. So as a disclosure, I'm the executive editor of it today. After Ron died, I asked his wife if I could continue it, and she said yes. Everything I'm going to talk about today are from the PADS, the Pediatric Anesthesia Article of the Days, and these were the top-rated articles of the months and years, and I'm covering the last 2+ years in today's lecture. And I concentrated not on all of the articles, but on the ones that dealt with bubemeises, urban myths. I have no financial compensation from work in the PAD, but it has been a lifesaver for me because I think I might have otherwise failed retirement. Now, from any of you who would like to, the PAD by design is free. And it will always be free. That was one of the things I did with his wife, and that was Ron's commitment. And if any of you would like to sign up, if you just grab a screenshot of this, you can just go to the QR code and sign up. And if on the flip side, if you have an article that you think is something that is important for us to review that I more than likely have missed, click on that link, and I will be more than happy to add that to our list. Okay, now the actual lecture. So look, there's a whole bunch of beliefs that have been ingrained in all of us that are really not based on facts. I like to call them vampire ideas. You just can't kill them. It doesn't matter how much the literature does it, as much, there's no evidence to back it up. You just cannot kill these ideas. And my thought is that just like other things, the only thing that can kill these bad ideas is sunlight and bringing it to the surface. Okay, so what are the ones we're going to talk about today? We're going to talk about a whole bunch. So, and I'm not going to go into the depth that you're used to in anesthesia, grand rounds, but these are the topics I'm going to discuss. NPO guidelines, maintenance fluids, the Allen's test, bicarb during cardiac arrest, how to manage the difficult airway, cefazolin and penicillin allergy, mechanical ventilation in the OR, keeping the CO2s in the low 30s, and finally, opioid-free anesthesia, which I know is a big deal here and is something that I'm going to make sure that I concentrate on the end because this too is a myth. Okay, let's talk about NPO guidelines. I would say that this topic has been amongst the most common of the articles that we've reviewed in the PAD. Now, the goal of NPO guidelines is pretty clear. You want to prevent the aspiration of gastric contents, which means that the stuff in the stomach is of importance. What's the pH of that fluid? Is there particular matter in the fluid? What's the volume? And the ASA, and I would say since I was a resident 50 years ago, the rule has been the 6-4-2 rule, 6 to 8 hours for solids, 4 hours for breast milk, 2 hours for clear liquids. Now, the important thing to know is that if you exclude people who clearly have a problem with an obstruction, small bowel obstruction, pregnancy, final trimester, aspiration is really very uncommon. And when it does occur, it has almost no effect. It's really a very minor thing. And despite the fact that it's so uncommon, it's still a frequent cause of cancellation. You know, the kid ate or drank, whatever it might be. So we also know that even if you go down to just the 2-hour fasting for clear liquids, and whatever a clear liquid is, most people actually fast for much, much longer than that. The average is really 6 to 8 hours. And prolonged fasting is clearly not a good thing for most children, and in fact, even most adults. I mean, if you think about yourself, the first thing you do in the morning when you wake up is you break your fast and drink a glass of water. Now, this concept of changing this has been in, I would say, at least 5 articles a year over the past 3 years. And if you sign up for the PAD, you can actually search, there's a search function in it, so you can actually look up these articles and the reviews by yourself. So let's start with it. This is like one of my favorites. So this was an ultrasound evaluation of gastric emptying times in healthy term neonates who were not fasted for clear liquids, but fasted for formula. Now, it's very important to underline something. I'm going to do it again in a moment. One of the ways that people evaluate this issue is they do focused ultrasounds to look how much fluid is in the stomach. The important thing to know is there's no connection whatsoever between how much fluid is in the stomach and the risk of aspiration. It's a surrogate marker that really fails the test of validity. But let's look at this for a second. So remember, this is for formula. There's literally no difference in the volume in the stomach between 60 and 120 minutes. There really isn't any reason whatsoever that for the 2-hour fast, even for formula, which according to the ASA guidelines should be 4 hours. There's no advantage in waiting beyond an hour. And in another study, they looked at different levels of clear liquids and also found that if you had just plain water, there's pretty much nothing there at 30 minutes. And even with high caloric sugar containing fluids, there's not much beyond an hour, hour and a half. And you can see that down here in this corner of the slide here, where there is, once you pass about 50 minutes, there's really not much left in the stomach after even formula or clear liquids, or any clear liquid. So do we really need a 2-hour fasting period for clear liquids? And the answer is probably not. Now, we're stuck in the United States by ASA guidelines, which still have the 2-hour limit. But in much of the rest of the world, it's now down to an hour. And in fact, in some countries, not only have they eliminated the fasting period, when you arrive in the pre-op area, you're given clear liquids. You're given a glass of water. And again, remember that there is no connection between the ultrasound volume and actually the risk of aspiration. That was first described by Mark Scheiner in, if you look over here, 1998. So this is not, there's nothing new here, but you can't break into people's consciousness that this no longer is necessary. Now, the most recent one is this one down here, which was just published in the British Journal of Anesthesia, and we just posted this in the pad, in which the entire country of Switzerland went to 1 hour fasting. And there was actually no difference in the risk of aspiration in the patient, in the period before they made the switch and after. They previously had a 2-hour period, fasting period. They went to 1 hour nationally, no difference in the of aspiration. Now, I should tell you that there's a major flaw in the study, which we discussed in the pad, and that although people are said to have been fasted for an hour, if you ask the parents, most of them actually, for the majority of the patients, more than 50% actually had fasted for significantly longer, which is the real problem with fasting guidelines. Parents just will just feed their kids. So in summary, 1 hour really doesn't, 1 hour should be the rule for clear liquids. 2 hours is more than enough even for formula and breast milk. And the idea of just giving people clear liquids on arrival in the pre-op area, assuming that it takes an hour to get from pre-op to the ORs, it makes a lot of sense. Okay, maintenance fluids. So this has been the mantra of how to give children fluids since I was a pediatric resident 50 years ago. The 4-2-1 rule, 4 mLs per kilo for the first 10 kilos, 2 for the next 10 kilos, and then 1 forever. Makes no sense whatsoever for anesthesia, because the reality is it's based on caloric needs, and when you're anesthetized, your caloric needs are lower. So the rule itself absolutely makes no sense for the pediatric patient or any patient in the modern time. I only bring this up because the amount of fluid is really irrelevant. It's the nature of the fluid that's important. You need to be sure to not use hypotonic solutions, especially solutions that don't have enough sodium in them. The risk is if you give too much of the hypotonic solutions, you're going to develop hyponatremia. The flip side is, although you don't want to use hypotonic solution, there's no reason to use what I prefer to call normal saline. You should not be using abnormal saline. Normal saline is an abnormal solution. It has too much sodium and too much chloride. And that means you're always at risk of making people have hyperchloremic acidosis. So the real reality is, and this came in our review of the PAD from the European Journal of Anesthesia, on this article on the consensus statement on intraoperative fluids, avoid hypotonic solutions. Most patients don't require any glucose. The only patient population that may require glucose are children less than 5 kilos in that first few months of life. If you need to give glucose, give it on an infusion pump and an infusion rate. Don't bolus patients with too much sugar either. And never, ever replace intraoperative fluid losses with hypotonic solutions. And that's the risk of giving something like D5 half normal on your solution pump for most pediatric cases. And again, if you think about it, it's really unnecessary. Okay, next, the Allen's test. So you can see that we're going through, this is a challenge for most of you because you're not going to be able to get on your phones and zone out. I'm going to just be rolling through multiple things that are important for you to know. The Allen's test. Everybody has been taught that before you put an arterial line in, do an Allen's test. Make sure that the ulna still has adequate circulation. And this paper, which we discussed, actually 2 papers, looked at literally thousands of arterial cannulations. And the important thing is it's a completely irrelevant test. It doesn't give you any information whatsoever. And it's really not even, it's no longer useful because of another reason that actually when I wrote the pad, I didn't put in our discussion, but one of the readers pointed out. So we have a reader response every Friday where people will review the pads and put their 2 cents in if they think there was a mistake or an error in our writing. And one of the people pointed out, and this is a really valid point, that most people in 2024 use ultrasound to put their arterial lines in. It's not required the way it is for, say, an internal jugular cannulation, but increasingly people use ultrasound to do this. Well, when you ultrasound the wrist, you have a much better clue. You're going to see the ulnar artery as well. That's a much more valid way of assessing both arteries than the Allen's test. So my suggestion and the suggestion of the pad is, it's a bad test. It doesn't really tell you anything. Don't bother. Okay, another topic. Sodium bicarbonate use during pediatric CPR. Now, we're going to take a break for a second because I need you to pull out your cell phones. So I need you to pull out your cell phones right now. You all have them. So stop looking at your mail for a second. You all have to have this app on your phone, the PD Crisis app. You can either get it in the app, and it's good for both Apple and Android phones. It works in both systems. This is a vetted product from the Society for Pediatric Anesthesia. It is a fantastic program to have on your cell phone because in a crisis, you should always do the same thing. Declare an emergency, call for help, open your iPhone to the app. So you can get this app by either looking up PD Crisis app or you can go to the Society for Pediatric Anesthesia's website, but this should be on your phone. And one of the really great things about this, it takes advantages of the power of the cell phone. So for example, if what you have to do is call the ECMO team as part of the algorithm, who knows the number of the ECMO team? Nobody. But when you get the program and load it up, you can put all these phone numbers in. There are spaces, it asks you to put the phone numbers in. So where on the algorithm, it says, call the ECMO team, you touch it, it will use the phone to call the ECMO team. Similarly, in a crisis, if you have to give a certain amount of a drug, it's hard to have your brain function properly. You know, this is the land of Dr. GABA and simulation. But the reality is in a crisis, it's hard to remember anything. There's just too much input. It's hard to concentrate. What's great about the program, again, is it takes advantage of the power of the cell phone. So if it says something, it'll ask you when you start a case or problem, what the patient's weight is. If you say 10 kilos and the dose is whatever it might be, it'll calculate the dose for you for all the emergency drugs. So this is an incredibly powerful tool that should be on all of your cell phones, and you should think of using it whenever there's a crisis. Okay. Now, one of the things you won't find in the crisis algorithms is the use of bicarb. Bicarb was once as ubiquitous in use as epinephrine in an arrest. And it's important to know that bicarb is incredibly hyperosmolar. It's 2,000 milliosmoles per ml, per liter, which means that it's very easy to overdose somebody on both sodium and bicarb. And the bicarb is a problem. it's going to cause all kinds of problems, most important of which are paradoxical intracellular acidosis. Now, when you put bicarbonate in a patient who's acidotic, you're going to produce CO2. If you don't have a method of getting rid of that CO2 is going to diffuse into cells and cause intracellular acidosis, worsening the actual systemic acidosis that's already occurring. And this is particularly a problem in the brain. What this article showed was that the use of bicarb in pediatric cardiac arrests actually increased mortality. And usually, when you're in a crisis and things aren't going well, the mantra in your brain always is, well, we got to try to do something. Well, trying to do the something with bicarb actually makes the situation worse, not better. And in this study, and we got a lot of reader back and forth about it, is that bicarb just makes things worse. Now, there are exceptions to this, obviously. If you're hyperkalemic, that's a different story. But for most cardiac arrests, the use of bicarb should go into, is another Bubba Misa vampire idea that really should not be done. And again, one of the great things about the pads are not only do we discuss this and discuss the results, but we also provide the links if you want to download and read the article in its entirety. Now, we can't, unfortunately, post the articles in its entirety because the way the companies that produce publications make their money is by charging for the downloads. So you all don't have that problem because you, I'm sure, have access to the Stanford Library, and it'll give you the PMID code to just click on it and just go to your regular library to get the article. Next topic, the difficult airway, everybody's nightmare. Now, a lot of times, and a lot of kids, the difficult airway is pretty obvious. Something like the Pierre-Robin syndrome. It's pretty obvious that this is going to be you're going to have a difficult time. But it's not always so obvious. And there are some basic rules that are different in 2024 than they were in previous years. The first thing is, whenever you suspect a difficult airway, and I would say all newborns should be suspected of having a difficult airway. All newborns should be thought of that way. You need to not just pre-oxygenate, which I think most of you would do, but you have to maintain passive apneic oxygenation during the entire process of intubation. Now, this is such a big deal that in some places, this is now a check mark on the actual EPIC forms. You should always be thinking of giving supplemental oxygen during intubations, whenever a difficult airway is expected. And to be honest, it should be used all the time. And there's a great little teaching thing that you can do amongst yourselves, is do a couple of patients with apneic oxygenation and a couple without apneic oxygenation. And it doesn't have to be a difficult patient, just anybody. And look to see how long it takes for people to desaturate. And you will see that in the group that isn't getting supplemental oxygen during the period of apnea, they will desaturate much, much faster than the ones who do. How do you give it? There's a whole bunch of ways. The simplest is just to put on nasal cannula and just supply 4 or 6 liters a minute through the nasal cannula. And if you use the nasal cannula technique, you can easily put your face mask back over it. Now, it means that you have to have 2 oxygen sources, one for your regular circle and one from the side port, but every anesthesia machine has that. So you should always think about having nasal cannula on patients who you're going to intubate, really just in general, but particularly if it's going to be a difficult case. The other way that people do it is they'll put a nasopharyngeal airway with an endotracheal tube connector in it and then hooked up to oxygen. Some people will use a second tube, usually a ray tube in the side of the mouth to give supplemental oxygen. But to be honest, I think the simplest way to do it is with nasal cannula because you're going to need that at the end of the case and transfer it back to the PACU anyways. So that's a really simple way to do it. Now, the ASA came up with a difficult airway algorithm. The journal in the journal Pediatric Anesthesia, we copied. They had this infographic that was a particularly good one. So I have it in here. Again, you don't have to take pictures of this, but it's all in my slide lecture things that are left here. So you can download this if you like. What are the basic rules in difficult airway? So the most important is this supplemental oxygen during the whole procedure. But the first attempt should be your best attempt. The first attempt should be your best attempt. And the data is now overwhelming that video laryngoscopy is really what you should do first, better than standard direct laryngoscopy. Now, I'm not telling you what kind of video laryngoscopy to use. My own thinking is that it's much easier to use the straight, normal Miller blade in a video laryngoscope than the curved angulated blade, which is a lot more tricky to use. The advantage of using the video laryngoscopy is that the other people in the room will see what you're seeing and can assist you in the intubation. They can manipulate the neck. They can sometimes pull the tongue forward. They'll see what you're seeing, and it will make the intubation much, much easier. If you're not successful, which happens, it happens to everyone at some point in their career, don't persist with a failing technique. And that might mean asking somebody else to do it. Or it might mean changing the laryngoscope that you're using. Or there are a lot of different things you can do, but if it's not working, if you fail twice, don't try again. Get somebody else or do something different. And the final word on that is, especially if you know it's going to be a difficult intubation, make sure that the most experienced person in the room does it, or is at least there for the second or third attempt. Now, this is the Bubba-Meisel one. This is the part of it that is the vampire idea. The idea has always been not to use muscle relaxants in a difficult airway. It turns out the data is overwhelming that using paralysis makes it easier, and it makes it more successful. So don't hesitate to paralyze. And although this goes without saying, it was a shock to me when I read the articles, and they all were from the UK, and they were published mostly in the British Journal of Anesthesia. Capnography is not uniform in much of the world. Once you intubate, you have to have some method of confirmation. And the only really effective one, the one that is the gold standard, is capnography. So don't forget that. You've got to use capnography. Now, the catch is you have to have circulation, but capnography is routine. And that was a shock to me that this was not a universal concept throughout the world. It isn't. Now, I should say the pad is read has 66,400 readers a day now. And it's in 70% of the readers are in the US, but 30% are overseas. And it's read in 98 countries. Interestingly, the only country that doesn't allow the pad, it blocks it. And I have no idea why, is China. So China, the pad is not available to the Chinese people. But I can't even there's nothing political. Oh, there's sometimes political things in it, but it's pretty uncommon. Okay, surgical site infection. My bet is that if you look at 10 charts, a third or more will say penicillin allergy on them. So what do you do for your surgical site infection when a chart says that the patient is penicillin allergic? And when I say penicillin allergic, and in the context of anesthesia and surgery, we're really talking about cephalosporins and really cefazolin, which I like to call orthocef, to be honest. But they're the key drug. So if you can't use cephalosporins, then what do you use? Well, you use something that isn't good. The alternatives are not as good. And this paper which was published in Pediatrics, looked at, well, what is the risk of using cephalosporins in penicillin allergic patients? And the answer is there's almost no risk. And that's because when you're allergic to penicillin, it's not the beta-lactam group that you're allergic to, it's the side chains. So you could be allergic to penicillin, but have no problems whatsoever with cephalosporins. And in fact, that's how you should look at this, that if somebody is penicillin allergic, there's absolutely no reason not to use a cephalosporin. And the alternatives to using cephalosporin, clindamycin and vancomycin, are not only more expensive than cephalosporins, but they don't work as well. So why use something that isn't as effective and is more expensive when the simple solution is simply to use a cephalosporin? So again, this is a widely commented upon pad, and it just ruptures one of the classic things that occurs every day in the operating room. It's not necessary. So just use cephalosporins. Okay, next. Now, there are a couple of people in the audience who I helped train as residents and fellows, and this is a topic that is of particularly great interest to me, and that's how we ventilate patients in the operating room. And if 100 people are marching forward and one person's going to the left and 99 people are going to the right, it's pretty obvious that the person going to the left is wrong, except in this case. I absolutely admit that I'm going against the grain here. And this article was entitled, CO2 is Good for You. And in this article, it talked about the use of permissive hypercapnia during routine anesthetics. Now, if you go into any operating room in the world, and I've been in many operatings throughout the world, when patients are mechanically ventilated, the end tidal CO2 is always in the high 20s and low 30s. Now, this is a completely abnormal physiologic state. When you are hypocapnic, when your CO2 is low, you're producing alkalosis, and that's not a good thing in the operating room. You're much better being acidotic in the operating room, and I'm going to show you why. If you let somebody breathe spontaneously, if you're not mechanically ventilating them on a vapor anesthetic or in TIVA, although in TIVA it's not as common, but especially when you're doing a vapor anesthetic and letting somebody breathe spontaneously, their end tidal CO2 is going to be around 52. Now, if they're very deep, it might be higher. If they're very light, it might be lower. And in fact, letting somebody breathe to their own set point is one of the easiest ways to know the depth of anesthesia. At MAC, let's just call it, your end tidal CO2 in a patient breathing spontaneously is 52. This is the target we should be aiming for. Now, why is that? Remember, hypercarbia produces acidosis. Hypocarbia produces alkalosis. Without exception, and the only exception really is the last trimester of pregnancy, alkalosis and hypocarbia is never normal. We're designed to function through evolution in the presence of hypercarbia and mild acidosis. We are not designed to be alkalotic. Now, I'm not talking about patients with head trauma or who have high ICP, and I'm not talking about people who have pulmonary artery hypertension. I'm talking about the 99% of the world who don't have those issues. And that 99% of the world, being hypercarbic, acidotic, is actually quite helpful during an anesthetic. Now, why is that? When you are hypercarbic, you increase cerebral blood flow. That's great if you're inducing an anesthetic with a vapor. It's going to, or really anything, because it's going to deliver more anesthetic agent to the brain. And that's your goal. Similarly, it's going to help take stuff away at the end. It will increase coronary artery blood flow, renal blood flow. It increases your blood pressure and heart rate. All of the things that you're constantly fighting during an anesthetic. Simply making the patient hypercarbic will help that. Oop, I gotta go backwards. Let me go back up. But the other thing is this. Blood flow is important, but really what's important is oxygen delivery. And remember this oxygen dissociation curve. When you are hypercarbic, you're going to unload more oxygen to all the tissues. If you are hypocarbic, which is what you usually do, is you shift this curve to the left and you don't unload oxygen. So one of the worst things you can do to a patient who is in trouble is to make them hypocarbic, because you're going to prevent oxygen from getting to the brain and other vital organs. Whereas hypercarbia will help unload. But the real secret for why hypercarbia is important is because hypercarbia, CO2, is what controls ventilation. So this is the normal CO2 response curve, this green line right here. As CO2 goes up, your ventilation goes up. These curves are shifted to the right and flattened if you have an opioid or a volatile anesthetic or a mixture. How many times have you done a case, and you've all done this, where the CO2s are in the high 20s or low 30s, it's the end of the case and the patient won't breathe. So you can't get the residual anesthetic off. This happens every day. Of course they're not going to breathe. They're not going to breathe because their CO2 isn't high enough. If you simply let the CO2 be in the 50s, they'll breathe right away. And as they breathe off their anesthetic agent, these curves will shift back to normal and they'll breathe faster and harder. In the old days, when I and some other members of the audience were just in training, there actually was a dial on the anesthetic machine to take the CO2 canister out so you would rebreathe CO2. And old anesthesia machines actually had CO2 canisters on them specifically to blend in at the end of a case to help people breathe more. You don't need this extra equipment which can fail. You simply have to let the patient breathe or control their breathing to have their end-tidal CO2 in the 50s. Okay, so allowing the CO2 to be higher will do a faster induction, faster exit at the end of a case, and it makes finishing the case much, much easier. Okay. And I'd like to conclude, and if I have time, I have one extra one. I have an extra one at the end, just in case. And this is a big deal in this institution because this institution is a leader in this anesthesia-free, opioid-free anesthetics. So this paper, if there's one paper that you should download the actual paper, and it's about 5 pages, or read the pad, which goes into it in great deal, was written by Evan Karish, the former editor of Anesthesiology, and it's entitled Opioids and Public Health, the Prescription Opioid Ecosystem and Need for Improved Management. Basically what this article says is that opioid-free anesthesia is nonsense. It makes no sense. It has no basis in fact. So let's do a very brief history of some of this. So the poppy and the production of opium is one of the, it is without, other than perhaps alcohol, it's probably the oldest drug that's been used in medicine. It's got a history of at least 5,000 years. And the reason it's been used for so long is because it works. It works. So why not use something that works? Now, the other interesting side message to tell you is that in the first recorded uses of opioids from the ancient Sumerian texts, which despite my age, I don't know how to read, but was used for dysentery. So the thing to remember about this is that the primary effect of opioids is bowel dysmotility. It constipates you. So if you're going to die of dysentery, this is a fantastic drug.
But it also means that whenever you give anybody an opioid, you're going to get constipation. It is as key to its function as is the analgesia. There are more opioid receptors in the gut than there are in the brain. So whenever you use these drugs, you need to have some battle plan to deal with constipation. And we have this constant swinging back and forth since the time of the American Civil War. Too much opioid because of addiction, stop using it. Patients are in pain, and pain is unnecessary, give it. And we keep going back and forth between too much, too little. And look, there's a reason people are worried about the use of opioids. In the US, at this slide, it was 70,000, and still around 70,000 deaths a year related to opioids. There's another 30%, it's about 120,000 people die a year of drug overdoses or from other drugs, but the vast majority are from opioids. So of course, there is a need to do something about how opioids affect our population. But here's the paradox. Over the last 5 to 10 years, we've really dramatically cut back how much opioids we've dispensed to patients and used in the operating room. That's demonstrated by this black line here. But the number, it hasn't affected the death rate at all. In fact, the death rate has increased during the same period of time. And that's because what's killing people in our current time is illicit fentanyl. It has nothing to do whatsoever with the drugs we prescribe and the drugs we use in the operating room. And there really are very few cases that I know of that can be where opioid use in the operating room resulted in a patient becoming having a substance abuse problem post-operatively. They're separate issues. It's true, and unrelated. There are real big issues with the opioid supply, but it's not their use in the operating room. This idea of opioid-free anesthesia will somehow affect the death rate is a bubba misa. It's just not true. And I would urge you to read this article because it's a fantastic article. Okay, there's this constant too much, too little, but one of the things we know is that when patients are prescribed opiates to go home with, they often don't use all of the drug. And in fact, my bet is if you've ever had an opioid for whatever reason in your own lifetime because of an injury or post-op surgery, whatever it might be, my bet is that bottle of oxycodone is still in your medicine cabinet. It's very difficult to get rid of opioids. No one is going to go to a police or fire station to put it in those boxes. It's never going to happen. And we know that patients and parents don't do it. So if you wanted to be a good citizen and dispose of the drugs, how do you do it? And again, there's really not a good answer to this problem. Probably the best way to do it, quite frankly, is to just flush it down the toilet. Now, the EPA, the Environmental Protection Agency, doesn't really want us to do this. It'll make the fish a little bit easier to catch, perhaps. But the reality is, a lot of people would like you to break down, to bury or mix the leftover opioids with things like kitty litter or soap detergent or something. The problem with that is that still gets into the water supply. It just takes a lot longer to get into the water supply because it goes into landfill. So in 2024, there's still really not a good way to get rid of opioids. So my own sense is that how to get rid of them still remains a big problem. But the flip side, and what our most recent articles in the PAD have been about, is intranasal naloxone. My belief is that when I was a kid, and when you were kids, your parents all had syrup of ipecac in their medicine cabinets in case there was an accidental poisoning. My own belief is that every household should have intranasal naloxone. And we had an article about this just recently that Rita Agrawal, your colleague, was one of the authors, or maybe the senior author, that we discussed in some depth in the PADs. So intranasal naloxone is something that you should all be carrying around. I have it in my car, and I still wear a fanny pack sometimes, not as much as I used to. I have it in my fanny pack. So, and I convinced my children to do this. One of them is a once a month DJ, and he resuscitated somebody at one of his parties. Think of how many people have taken CPR training, just for a second. Think of everybody you've all been forced to take CPR training, and you're physicians and nurses, but the entire population has been forced to take CPR training. If somebody arrests, the likelihood that somebody will use CPR is close to zero. And even if they do, the likelihood of a good outcome is pretty close to zero outside of the hospital. If we just walked around with this, we'd be saving thousands of people's lives. Now, there are certain patient populations that are at high risk. And I would say patients with sleep disordered breathing, if they have co-administration of other drugs with their opioids, and the other drugs don't have to be the drugs you think of, it could be drugs like alcohol, teenagers, history of depression. But I think probably and we had a recent article about this in the PAD, if you want to look at what the real trigger of substance abuse is in most patients, it's a history of physical, emotional, or sexual trauma. If you have if your patients have any one of those three things, having intranasal naloxone at home is a very big deal. Okay, so we went through a whole, is there enough time for one more vampire idea?
Sure.
Okay.
Small vampire.
This is a small, this was, I have to be honest, my favorite article of the year. It was in the journal Pediatric Anesthesia. It was written by one of the real leaders in our business, Britta von Unger-Sternberg. And it turns out that honey is a very effective analgesic and antiseptic. And there is an increasing sort of desire, especially in tonsillectomy patients, to either have the surgeon instill honey over the eschar in the tonsil bed, or to at least encourage people to take honey during their recovery because it produces immense analgesia, and it actually is quite tasty. So today I went through a whole bunch of myths and misconceptions that still rule the roost in anesthesia. You can learn more about this by subscribing to the PAD and reading it daily. And if you decide after a bit that you don't want to receive this in your mailbox, it's very easy to get it off as well. So with that, I'll say thank you, and I'll take some questions.
Myron, just one thing, I think you should tell everybody that the pads. Myron, thanks. This was great as always. Tell people that the pad is written to be read in 5 minutes or less.
Yes, I am so sorry. Key thing. So aside from the fact that you can't even, it's impossible to read the articles. It takes a while to read the articles. The pads are designed on purpose to be read, and it should not take more than 5 or 6 minutes to read the pads. And what I encourage people to do is to read the pad when they get their morning coffee break. And especially for those in an institution like this, where you have often students of one sort or another, whether they're anesthesia physician students or nursing students or physicians, anesthesia assistants, whatever it might be. If you're in a teaching institution, this is a great way to teach a new topic every day, because all of these things have real impact on your daily anesthetic experience. Now, we don't only publish things from the journals that you can think of. We also publish articles from Scientific American, the New York Times, the Washington Post, about things that your your patients are going to be asking you about. So it's a very wide spectrum of articles. But again, as Elliot pointed out, these are 5 to 6 minute reads. So they're designed to be quick and they're designed to have an opinion. So you're not going to get an article that says, honey is great without somebody saying, yeah, this is a good idea, or saying, oh, this is bullshit. I don't believe any of this stuff.
I don't see any questions online. Any other questions from the audience?
Thank you for your talk. Could you just describe a little bit about how you developed the Society for Pediatric Anesthesia?
Oh, it's a great story. So this is, so I did a pediatric residency and an anesthesia residency and fellowships in pediatric anesthesia and critical care. At the time, the only way, this is in the late 1970s, the only way to do pediatric critical care really was via anesthesia. So there wasn't like a pediatric track at that time. There was no board in it. So when I finished my training, there was an organization at the time, it still exists, and Rita has been, I know, very involved in it, called the American Academy of Pediatrics Anesthesia Section. So I naively filled out the application, sent it in, and I was rejected. And I was pissed off. I mean, there was steam coming out of my ears because I was eligible to be a member of the AAP because I was a board certified pediatrician. But I didn't meet the criteria of the anesthesia section. Why? Because you had to do 90% of your time in pediatric anesthesia. I was at Johns Hopkins and I did adults as well as pediatrics at the time. And I did PICU, which didn't count as pediatric anesthesia. So I was really furious. And I went to my department chair, Dr. Mark Rogers, and I was like out of my mind. I was just crazed. And he said, "What are you complaining to me about it? Do something about it." And I realized that we needed a society for pediatric anesthesia, not of pediatric anesthesiologists. And Mark gave me a budget that I was able to use, and I was able to bring together a whole bunch of people to start the organization. And at the first meeting, do you all know George Gregory? I know he lives just across the bay here. I don't know how many of you have had the privilege of working with him or knowing him. But we had this meeting and there was a decision to go ahead. And I asked George to be the first head of because I was 18 months out of my fellowship. I was not who I am today. I was a baby. And George just looked at me and goes, "No, you got us all here together. You should just keep going." And when the meeting was done, Bob Crone, who was the head of the PICU at Boston Children's and the vice chair of the department, pulled me aside and goes, "You have no idea what you just pulled off." And I said, "Well, what do you mean?" He goes, "A lot of people have tried to do this, but you were so insignificant that you flew in below their radar." That's how it started.
I don't think we can top that. So your great insignificance, Dr. Myron Yaster, thank you so much. It is truly an honor having you here.
Thank you. Thank you so much.